Welcome to the St Emlyn's podcast. I'm Iain Beardsell,
And I'm Simon Carley.
and this is our update about the blog post from March. We are trying to catch up, Simon. We are busy people. Well, you're a busy person, and we are getting there. And there's a lot to talk about in March. Before we do, just a quick thank you to you all for listening to St Emlyn's and reading the blog and subscribing and all of that. And if you have downloaded MedPod Learn and are using it, that's also great. Please do take a look at it. It's another way to get the most out of medical podcasts and even be able to log all your activity for appraisal. It's free to download and you can give it a go for a month. And even after that, the monthly subscription is very low, but hopefully trying to recoup some of the development costs associated with making something like that. So do take a look. And thank you again to Galen and Intersurgical for their support. Without them, we wouldn't be able to do what we do. Free open access medical education is never really free, and we do need external support to help us keep doing what we're doing. So we really do appreciate it. But Simon, let's crack on straight away. No messing around with some medicine and lots of evidence. And we start off with the 2026 PE guidelines, pulmonary embolism guidelines, written by the fabulous Rich Carden. PE is just one of those. If PE didn't exist, I reckon emergency medicine would be twice as easy. And if aortic dissection also didn't exist, that would be it. No PE, no aortic dissection, I'd skip into work. But do you think this new guideline helps, hinders, makes things easier? And tell us a bit more about it.
There's a graph in here which I thought was really quite remarkable. And it shows the incidence of PE as any diagnosis. Incidence of PE is a primary diagnosis and mortality over the years from 1993 to 2006. So a bit old data. But essentially, what happened in 1998 is that multi-detector CTPAs were introduced. And at that point in time, the incidence as a primary or as any diagnosis of PE has shot up and continues to shoot up. Mortality from PE has remained entirely the same. Really interesting. We've not really shifted the mortality. We maybe a little bit over that period of time. And so what's happened is we're now diagnosing large numbers of PEs, which in the past wouldn't have been spotted. And in particular, we have sort of, we'll talk about it later, but high level PEs, low level PEs, and sometimes we've got PEs which are so subclinical, they're just incidental and asymptomatic. And we see that in trauma scans, don't we? Quite a lot of the time that we'll see patients who've got two platelets holding hands in some peripheral capillary in a lung. Is that a PE? Probably not. So what these guidelines have done is taken a bit more of a pragmatic approach, which I like, to PE stratification, and then gives us indications about what to do depending on how severe it is. So it goes from an A to E strategy. So A is the subclinical, incidental, asymptomatic, which are clearly lowest risk. And it goes right through to those E-level PEs where you've got cardiopulmonary failure, and particularly cardiopulmonary failure. In the past, I think we've often thought about PE as a cardiovascular type problem, but of course it does cause, in large amounts, it causes pulmonary failure as well. So that was really interesting for me. Risk stratified, there's a strong emphasis here that we shouldn't just default to CTPA for everybody because we're likely to cause more harm. And we should be risk stratifying those patients from the diagnostic pathway about who are we going to CTPA, which is the diagnosis of choice for those who can have it. But do that using a risk stratification tool plus or minus a D-dimer, then CTPA them. You can use things like VQ SPECT, which is better than plain RVQ when it's available, but it's not as good as CT. Interestingly, echo, which is a lot of people have seen try and use to diagnose PE in the critically unwell patients, say, oh, the echo looks okay, it's not PE. Not really that helpful, to be honest. However, in terms of risk stratification, once a PE has been confirmed, then it can be very useful to tell you what the cardiac impact of this is. In terms of treatment, once you've got something where they're symptomatic or it's big enough, then give them a low molecular weight heparin. It's better than unfractionated heparin. DOACs, they're good for those patients who are suitable to have them. And in that intermediate group, so this are the patients who are often ambulatory, who come in with respiratory chest pain. You've investigated them, they've had a CTPA, they've got a PE, you need to treat them. They can treat them as an outpatient. I think we've got that pretty much sorted. The data around that's okay, and that's what this study says. In the high-risk group where you've got cardiovascular, cardiopulmonary compromise, the evidence isn't fantastic, really, because the data's all over the place. It's a bit messy. In the crashing patient, then, we're going to be heading towards probably thrombolysis, but whether that's systemic thrombolysis is better, whether it's catheter-directed, whether you go for thrombectomy, whether you go for surgical embolectomy, I've seen all of these done in my practice. It's really difficult to really come down on a hard evidence recommendation around that. And probably, you should certainly do, in the patients with cardiopulmonary compromise, you should certainly be considering some form of thrombolysis or embolectomy. And you probably need to speak to a PE expert or a PERT team, as they're often called, knocking around. But it's likely that you're going to have to make a case by case decision about what exactly is required there. The evidence just isn't strong enough to say that this is the definite treatment for that group of patients. So, yeah, really complicated, really interesting. Yeah, the big thing that I thought was really fascinating was how a new diagnostic modality had increased a huge number of people with a diagnostic burden and potentially pathology from that, but mortality hasn't really shifted. Fascinating.
And PERTS, and I think it has to be PERT, not PERT team. What with the T standing for team? I was listening to Scott on MCRIT, and these are obviously a thing happening in America. And maybe you've seen, I've not seen any of this in the UK to have a PE response team, but maybe they are coming. I'm always a little bit anxious about single disease or single presenting complaint focus. We see it in strokes, we see it a bit in trauma. I suppose we see it in chest pain and acute myocardial infarction. And I worry about the people who don't fit the obvious, this is a PE, and they don't get the same sort of attention. But do you think PERTs are something that we're going to be getting in the UK? Or am I just missing out? Are they around already?
I don't know whether it's labelled in my shop, but we certainly have a group of people who have particular expertise in the management of pulmonary embolists. And I think they offer a great deal of support in the cardiopulmonary compromised patients about making decisions about which particular advanced procedure we're going to go for. That's one of where I genuinely think they add value and I've used them. And the second group is in the patients who maybe an anticoagulation question is tricky because they have other risk factors that would put you against anticoagulation and making balanced judgments, often with patient involvement. So, yeah, I think there is a role for this scope. I think it often exists within the respiratory physicians, or people who've had a significant amount of respiratory medicine training. But yeah, I think the ones I've worked with, and I can think of a couple of individuals, have really added a huge amount of value. So, yeah, I think we can see this coming. Whether it's called a PERT, I don't know. It might just be Dr. Logs down the corridor has got a really big interest in PEs. If you've got any problems, just give him a call.
And I do think the decision to thrombolize or not thrombolize a patient is one of the big decisions we have to make. And it's one that I would always share with a senior colleague. And I think it's a 2 consultant or more decision, because I don't think, even after all this time, and where it goes way back to the days of SMAC when me and Swami even got a debate about this. I think there are some times when thrombolysis or advanced treatment is relatively obvious, cardiovascular collapse, that sort of business. But this guideline does move away from the diagnosis as submassive PE, but those more severe things, the choice to thrombolize or not, I think, is not straightforward. And I can't help but imagine we'll go the same way as we have done for hearts and we have done for brains. And instead of giving lots of clot busting drugs, somebody will go in and get the clot out. That seems to me the way forward, but I'm not a cardiothoracic surgeon. And some of the cardiothoracic surgeons I know may not be that keen to be part of a 24/7 on-call thrombectomy.
Yeah. Yeah, on that particular point, yes, you can do that, of course. You can go endovascularly and pull them out. Some of these clots are enormous. So it's not like doing a coronary artery where you've got small. So the clot burden can be huge, and then you're into surgical embolectomy. And again, yeah, it comes down to, I think you need experienced clinicians looking at the scans, looking at the patient, and making a balanced judgment on what's right.
Do go and read the blog post. It's got all of those diagrams in, which are actually really helpful and jolly colourful, actually. And the colour isn't just a graphical thing. It actually does help understand it. It's been published in Circulation, but have a read of Rich's post because it'll help you understand it. And then if you want, of course, please explore it more. Now, Stefan continues to produce loads of blog posts for us all about how emergency medicine works and how emergency departments function, or in some cases cease to function. And his post in March about the model emergency department capacity and demand. These are words that are thrown around all the time. And I have to admit, I have disengaged from this slightly. I turn up to work, do my best, and then try and go home. But for many, how to make emergency departments work more effectively is an everyday worry, concern, obsession. And some of these thoughts from Stefan are really worth thinking about if you're in anything to do with how emergency medicine and emergency departments work.
Yeah, I think I find these really fascinating. It's something that occupies a lot of time at college. At the moment, we discuss a lot of these things. This particular blog came out of the Model ED document, which came out of, I don't know, Department of Health, NHSE. I always get mixed up these days. It's all going to be the same organisation next year. But anyway, there is a document called the Model ED. And in that, it requires you to map your capacity and your demand. And what Stefan's done in this one is looked into that in a bit more detail. And there's some really interesting stuff that comes out of it, I think. The first is that 65% of the growth that we're seeing in emergency medicine activity cannot be explained by demographics. So yeah, yes, we do have an older population. Yes, we do have more comorbidities. Yes, we have different challenging healthcare needs and poor behaviors, etc., and etc., blah, blah, blah. But 65% of it cannot be explained by that. But what is happening is different access to technology. Supply-induced demand, I think, is a really interesting thing. It's the concept of basically you build it and they will come. And we saw this when we started opening walk-in centres in the community, is that it didn't reduce demand at emergency departments. It just meant that more people went to walk-in centres. Just by providing more services does not reduce demand. The other potential concern is that if you make your systems more efficient, so that if you can turn up in an emergency department, get an appointment, be seen within 10 minutes by a senior specialist and organised, do you know what? It's going to encourage people to go to emergency departments and turn up and get themselves sorted within 10 minutes. Now, I'm not saying that's a bad thing. I'm just saying that's a consequence, not necessarily intended, but an apparent consequence of when you do it. And so barriers actually control demand capacity. It's really fascinating. Point is, if you build it, they will come. It also tells us that just managing flow, which has been one of the things that we've pushed hard on, and in certain parts of the country we're getting on top of now, is that flow through the departments is improving in some areas, is that in itself won't manage the capacity issues that we've got. I was on another call with some very senior people within NHS recently, and the other thing that they were talking about, and they've got stats to support this, is the incredible variation in the performance, or not necessarily performance, but how things are done between different hospitals. You might look at that in efficiency, you might look at that in terms of patient care, you might look at that in terms of where we are now and what the potential is for the future. But really interesting stuff. I like Stefan's post. They challenge some of the simplistic answers that people put forward to emergency medicine. Just putting bigger capacity in, more doctors, more nurses, more support staff, and more space will not solve the problem. In fact, it could, paradoxically, make it work. And the final question is really, are we modelling what we should be doing for now? And I think that's where most of the effort is being put. And his argument is actually, come on, guys, we actually should be modelling for what we need to be and where we need to be in 10 years' time. Because if we just carry on as we are at the moment, we can't keep up with the increasing demands that we've got at the moment. We need to do things differently.
I'm a simple man, and I probably am trivializing the whole thing. What I don't understand is, why haven't we fixed this? This is a problem worldwide with bright people trying to find solutions. And I suppose in the end, it'll come down to the thing that gets in the way is people. But I'm confused as to why it is that we haven't fixed this. I've got, let's say, 15 years of my career left. I just wonder if it'll ever be fixed, or if this is just an intangible. Or would we even be happy, Simon, if emergency medicine was fixed and all of a sudden we had nothing to complain about and how bad it was? Do you think we'd still enjoy it as much if it wasn't quite so chaotic and mad?
I think we'd enjoy it if it was different. On the reason why it's not fixed, there's a great blog post we did many years ago by Craig Ferguson called "On the Wicked Problems." And that is a defined thing. A wicked problem is one which is actually unsolvable, and that's probably true. Great post, actually, if you want to go read it. So yeah, it won't be fixed, but it will be different. But I think the point in this one, the big takeaways for me are, it's not just about the demographics, number one. Secondly, actually, we need to prepare for the future, not for the present. And I'm going to put in, thirdly, just doing incremental change around what we're doing now probably isn't going to solve the problem. We actually need to do things fundamentally differently. What that looks like, got 15 years to figure it out.
On to another high-profile paper produced by a team in the UK, and one that many people will be aware of, the SWIFT trial. This is all about pre-hospital whole blood in traumatic hemorrhage versus blood components. And Hutch has done a journal club for us on this and an analysis. There's been an awful lot talked about to do with this trial online, on podcasts, and other places. I even came across old friend Ed Barnard talking on Behind the Knife, which is an American surgical podcast. I found it on MedPod Learn, if you wanted to know, Simon. He was part of this group too, and the group is one of high-level trauma physicians. And this was asking the question, should we be using whole blood to resuscitate people who are bleeding, or should we continue with blood components? And lots of pre-hospital teams across the UK have been involved with it. And the findings are interesting, to say the least. What were your thoughts, Simon?
Yeah, so I was involved in this trial. I recruited several patients to it. Essentially, it's looking at whole blood. So the idea is that the reason why we split off components into packed red cells and FFP and platelets is because it's more convenient and to do things with it. But it wasn't always the case. And one of the thoughts was that if you give whole blood, so not the divided components, without the calcium in because of the clots, then you don't get the same degree of coagulopathy, and coagulopathy is associated with death. Therefore, you get fewer deaths, so positive outcomes. That seems like a sensible thing to do. In my normal air ambulance service, we carry 8 units, which is 4 units of FFP and 4 units of packed red cells. We've spoken in the past about just how awful packed red cells are physiologically. They're acidemic as a substance. It's almost like cardioplegia. They're hyperkalemic. It's dodgy stuff. Anyway, whole blood is attractive. So this trial randomized patients who were pretty sick, well, they were very sick trauma patients who the clinicians had decided to give blood to or blood products. And you open the box, and in the box, you didn't know until you opened it and you blinded, you'd either have 2 bags of whole blood or you'd have your normal 2 units of FFP and 2 units of packed red cells, or in some cases, lyophilized instead of the FFP. And you just give it. And then we followed them up. And the primary outcome was death or major transfusion within 24 hours. Now, interesting, it's a pretty well conducted trial, lots of enthusiasm. I personally like the whole blood a lot more. It's much more efficient. It looked right. It felt right. It was good. The data showed that there wasn't any difference. There was 48.7% survival for whole blood and 47.7% survival as a primary outcome. So really sick group of patients, half of them died. Not really much difference in the subgroup analysis either, maybe more coagulopathy in the whole blood, which again was a bit of a surprise. So it's considered a negative trial. It hasn't really demonstrated. However, whether or not just giving 2 units in a group of patients who then go on, the vast majority of them to go on to very significant blood transfusions, whether that's enough to make a really big difference, I don't know. Maybe the trial could have been done with carrying on with whole blood throughout versus blood components. I think I would have liked to have seen that. And from a purely practical point of view, I wish we'd stick with whole blood because it's just a hell of a lot easier to use.
There's lots in here, isn't there? First thing, hats off to the trial coordinators to get this sort of thing done and up and running is brilliant. To do a trial in the pre-hospital space, we know is really difficult and it's hard to get people recruited. But it feels to me like there's a step change in pre-hospital services wanting to be research-led and wanting to be evidence-led and wanting to be involved. I know that my local service was involved with this as well. So really, to Jason and the team, huge hat tip to you. And I think we will continue to see changes. There's the practicality, isn't there? Is it easier to carry whole blood than it is the separate components? Is it easier to give? And I don't think that was properly really looked at in this. There was all sorts of other stuff coming, and Ed hinted at it in the podcast I mentioned with Behind the Knife about other ways in which we might be giving blood products. And of course, a lot of this is coming out of the work that the military are doing. And for all of the things that conflict brings that are negative to our world, the one thing it has helped us do is develop our trauma care for acutely injured patients. So lots to think about. Nothing to change now. It's certainly not something that we're going to be adopting widespread, but there may be cost implications and other stuff that means this hasn't gone away. And I think it'll be another thing. The main thing also, Simon, I think was it wasn't just about the type we were giving. It was, are you giving enough and who is carrying it? And in the States, very few ambulance services carry blood from what I understand, but those do seem to have backups where they have trucks full of blood to go. And I guess that's a multiple incident type, huge numbers of patient type problem that they have far too often in the US. So all sorts to think about, but I'm just pleased that these trials are happening. I think it's a great thing. And perhaps linked to this, Simon, is a thought about who can access HEMS, or in fact, who can HEMS get access to, and whether or not you have a physician-based HEMS service near you. And in fact, whether that helps. And of course, I know that you're a HEMS physician, and so you are signed up to this, I believe, as a good thing. Others may be a little bit more cynical about the costs of HEMS and whether it's an effective thing in the UK landscape. But this is about who gets access to it. And it is certainly not the same across the country.
No, so this was basically published in EMJ. It was basically a survey to look at what the capacity and the reach of enhanced pre-hospital care services are in the UK. So not just helicopters, but also attending by car. 21 air ambulances were interviewed, and the bottom line is it varies enormously. Only 50% of those are 24/7. Only 11 out of 27 of the responses had 24-hour doctors. 90% took blood, which is good, but then 10% don't. Only 5% do Reboa, which maybe it's only London Air Ambulance who does that. A couple of flaws in it. So basically, it tells us that there's huge variability. In the east of England during the day, I think you've got access to 5 physician-based, physician CCP helicopter services. And in the northwest of England, covering a population of 8 million people, we've got 1. The inequities are huge because there's no national mandate. These are all charities that can do whatever they like. The paper itself, a couple of things. It didn't include other enhanced pre-hospital care services. So there are basic schemes. So that's the volunteer side of enhanced pre-hospital care, which I'm also a member of the Northwest pre-hospital critical care charity here. We do also do quite a lot of enhanced pre-hospital care as well. So I think we're going to do 600 jobs this year or more, and not including them, I think, has missed a degree of components. And some of those services do carry blood products as well. So it's not perfect, but I think it tells us the picture. One, incredibly variable and therefore inequitable. And two, no national direction. So no national direction, no national standard. And that's what you end up with.
Pre-hospital care is a fascinating thing in the UK, isn't it? As Simon mentions, it's entirely charity funded, pretty much, apart from a few pockets where ambulance services may support paramedic provision. But this is all down to people putting their hands in their pockets and entering a lottery and putting a pound coin in a jar and going along and to a fate and being inspired to put some money in. And they are not cheap services to run, millions and millions of pounds. And there are obviously people who believe these are great things. And there's just a question in the UK health landscape: can they be afforded? And what is the benefit to the larger society? I know that for many, they will say it's a great thing. Simon, you'll be one of them.
Yeah, no, I'm fairly convinced that it does offer some value. Notably, there are pockets, aren't you? You're right. Notably, Wales and Scotland have got national funding to provide cover. So they have a different model. It's particularly in the UK, where they're in England and Northern Ireland, where they're county-led systems. Then it's all over the shop, as you said.
And continuing our conversation about out-of-hospital care, so transesophageal echo, I've probably only come across about in cardiac arrest in the last 6 to 12 months. I think it was when we went to London Trauma 2030 and I was chatting to Anna Dobby about some of the new things. And she said, oh, it's amazing. It's a great thing. And I was like, really? It just feels like another toy. But actually, TOE or TEE, if you're American and you don't like adding O's into words, guided CPR may be a good thing. And it's all that thing about nuancing what we do and making CPR more effective.
Yeah, so I'm a big fan of trying to improve CPR. It's something we've talked about a lot on the podcast. And what's behind this? We know that blind manual CPR, so you're doing CPR either manually or with a mechanical CPR, we know that one size doesn't fit all, basically, and that moving the position of the plunger or the position of your hands around the chest can make dramatic differences to the effect of the CPR, because the biggest problem being that you get left ventricular outflow obstruction with the compression phase. So you're pushing against a closed valve, basically, so nothing goes out. So you can either do, several things you can do. You can do TOE, which is what they've done here. Interesting, as an aside, I've had a TOE, didn't enjoy it very much, quite unpleasant, but great pictures you do indeed get. You could put an arterial line and measure what the pressures are. You could potentially do ultrasound transthoracic and have a look and see what's going on. So things you can do. Transesophageal sounds great. Put a probe down, you can see what's going on. You can move around the chest. Makes a lot of sense. In this study, so it was a cluster RCT, so they did clusters of patients. And what they were looking for is whether or not, if they guided the CPR by transesophageal echo, could they get more patients with a ROSC of more than 20 minutes? That was their primary outcome. And then they also looked about whether they got home. 132 patients randomized. Their TE, they got a ROSC in 44% of patients. With just doing the normal thing, they got ROSC in 39% of patients. That didn't translate to an increased number of patients going home. I don't know, what does that tell us? It's not big enough. So the trial's not big enough to tell us whether that 5% difference in outcome is actually important. With 132 patients, you were going to have a massive difference, and that probably wasn't never going to happen. So I look at this as a bit of a pilot concept, really. Second thing, and I think it's a big one, is that they weren't doing this until the patients got to the ED, and that was 30 to 50 minutes after their arrest. So if you think about it, the reason why you're doing this is because you're worried that your CPR is ineffective, and you're waiting 30 to 50 minutes until you decide whether or not it's ineffective or not, and doing something about it. I understand the practicalities, but realistically, if this is a modality which is going to make a difference, you're going to have to do it a lot quicker than 30 to 50 minutes in. It's going to have to be a scene intervention. So this might prove the concept, but if it's going to make a difference, it has to be close to the point of arrest. So maybe for in-hospital arrests, perhaps, or out of hospital, I think if you're going to do anything, you're going to have to take it to scene.
Whenever things get more complicated, I try and make them more simple by remembering what we're talking about. This is cardiac arrest where the heart muscle is not getting enough oxygen. And it's about trying to maximize that while you sort out the arrhythmia, or if there is a secondary cause as to why that has happened. And you're right, aren't you? The sooner that can happen, the better, because the heart is just dying. So if you're waiting half an hour or more, the heart has already died and your reversibility is going to be tricky. We need to do the best we can at the time the patient has their cardiac arrest, don't we? And that might be just optimizing through arterial line placement or whatever it might be. But I think you're right in that doing it in hospital is probably, unless the patient's had the cardiac arrest in hospital because they're on a
Yeah.
CCU and they're having heart something done, then this may be something that pre-hospital we are looking at when we're trying to nuance. But if you had to choose, and I'm not saying you would, between a TEE, and an arterial line in cardiac arrest, do you think there's an obvious choice at the moment?
And I've been asked that question several times, actually. And my personal view is that we should be going for the arterial line because arterial line tells you what the function is, not just what it looks like. And what you're doing is you're trying to generate pressure, or you're trying to generate flow, but you're also trying to generate a diastolic pressure above 35 to get coronary perfusion. So for me, an arterial line is the way forward. And that is something that can be delivered pre-hospitally. And it's something that we do on a regular basis now, intra-arrest art lines, femoral art lines, to tailor our CPR. So yeah, that's where I think we are at the moment.
Greg Yates has done a post here about pericardiocentesis for traumatic cardiac tamponade and whether this is a feasible alternative, particularly in low resource trauma care. Now, I was always taught, and this was many years ago, I was always taught that if you try to do pericardiocentesis for pericardial cardiac tamponade, there was a clot on both ends of the needle. I remember being taught it very well at a meeting, stroke teaching day in London, and regarding myself as feeling like the clot because I'd put my hand up and said, yes, I would do that. So it stuck with me. Talking again, as we have in the past, about negative feedback is the one you remember. But it seems that perhaps pericardiocentesis could be an option where you don't have other choices. I suppose there's an option of anything is better than nothing. And I think that's where this study maybe takes us, perhaps.
The first thing to say is remarkable and absolutely fantastic. I can't praise the authors enough. This study comes out of Gaza. So with all the things that are going on in Gaza, they've managed to form a number of procedures and record them and get them published. Massive kudos to everybody who's been involved in getting it to this point. And I think in that sort of setting where there's only one cardiac surgeon in the entire country, as far as I think the paper said, our normal approach to a traumatic pericardial effusion would be a thoracotomy. That's not an option. So instead of just giving up, what they've done is they've gone and put a large bore catheter into the pericardial space under ultrasound guidance. They've then aspirated as much as they can and vigorously and really quite hard, trying to get as much clot out as they possibly can. They've then injected TXA into the pericardium and then left the drain in for 48 hours. They did this in 25 patients, 24 of whom survived. 2 of them needed a repeat drainage during that period. And that's utterly remarkable. And as you say, Iain, it's completely contradictory to what we've been taught. A couple of caveats. The first is that the mechanism of injury, 24 of these were due to shrapnel. And that might mean that what we're looking at here is very small wounds. So they could, I don't know the size of them, but it could be small wounds with relatively brisk bleeds that then settle down, as opposed to somebody who's got a knife wound in the right ventricle, which isn't going to be resolved by this, I can assure you of that. So picking your patient might be a key issue here. And the second, it is small numbers and there's probably a lot of great patient selection. But actually, I really love this paper. I love papers that are contradictory to what I previously thought. And I love the fact that this remarkable group of humans who are trying to do humanitarian work in Gaza have had the time and just the ability to share their learning with us.
Important to say that, of course, these are patients not in cardiac arrest. So this isn't the idea of doing pericardiocentesis on the patient with a traumatic pericardial tamponade. But yeah, I couldn't echo enough the idea that you can think outside what you're doing in your clinical environment to write all of this down. Fair play. And also, they've clearly come up with something different in a horrific environment where they've had to think differently, and they've literally come up with something different and gone for it. And sometimes necessity is a precursor to excellence, isn't it? Simon, that's a jam-packed month. March was busy. Lots and lots of papers, lots of heart stuff, lots of trauma stuff, lots to talk about and lots to take away. We haven't given you the exact paper references as we've gone through, but please do go and look on the blog site. They are all there. And as ever, please don't take anything me and Simon say to be gospel, and never just believe anything you hear on a podcast. Go and check out the actual papers, read them for yourself, take them to a journal club, discuss them amongst yourselves. There are still aspects of the college exams and others that require you to be good at critical appraisal. So it's a skill that you really need. And in this day and age, it can be really rewarding to go and do that yourself. So don't just believe everything you hear on St Emlyn's or any other medical podcast for that matter. Simon, thanks again for your time. Lovely to chat to you. Thanks again to you all. Please do like and subscribe and keep listening to St Emlyn's, and we'll be back very soon as we continue our mission to get up to date with all of the blog post content we've been publishing over the last few months.